Good afternoon again. Thank you everyone for joining us today. Looks like most of the people are successfully gone into our room here for the meeting. We look forward to you joining us today for the Virtual Health Talk, a series that we've started now that we're unable to come out to you in your community. We're actually now able to come to your homes and offices and smartphones to make sure you're getting the information you need. Today we've got an exciting talk on updates in colorectal cancer screenings. Before we get started, we're just going to go through a couple of the housekeeping. At the bottom, you'll see the Q&A function. That's where you'll enter your questions. We'll be answering all the questions at the end. Dr. Soika will go through her presentation, and then we'll address any questions that maybe you still have that she maybe didn't cover in the talk, but I believe a lot of those questions should be answered in the presentation itself. There will be no video or audio from any of the participants, but you will be able to, again, type your questions in the Q&A. Again, thank you for joining us. We'll begin. I'll give you a biography on Dr. Soika and her background. She is a gastroenterologist and director of endoscopy at the University Hospital's Geauga Medical Center. She did her residency in gastroenterology fellowship at University Hospitals after becoming a doctor of osteopathy from New York College of Osteopathic Medicine. She also has a bachelor's in chemistry and in Spanish from State University of New York, otherwise known as SUNY at Geneseo. Without further ado, please welcome Dr. Caroline Soika.
Hi, everyone. Thanks for joining us here today. I know it's not the typical setting here in my home office, but I'm happy to present to you some stuff about colonoscopy, and this talk will be mostly about updates and guidelines and screening recommendations. A lot of questions have already come through which are addressed in this talk about stool testing versus colonoscopy testing, age with which to start screening process, et cetera, and then at the end, we'll address all the other topics and questions as Mark discussed. So without further ado, let's start the talk. This is a nice graphic to start with that just sort of drives the point home of how many people, how devastating colon cancer is. This year alone, over 50,000 people are expected to die of colorectal cancer, and screening could really save more than half of those lives. Why should we be talking about colon cancer? Because it's one of the most preventable cancers that we have, probably the most preventable cancer, I would argue. It's the second leading cause of cancer deaths, however. It's the second most common cancer diagnosed with women. There's about a 4.4% average risk of having colon cancer in your lifetime. So you can see on this graphic here, lung cancer being the most common leading cause of cancer deaths, followed by colon cancer right behind it. This graph here just represents the incidence of colon cancer. So despite all of our good treatments and surgical techniques getting better, the incidence of colon cancer continues to climb. And you can see here that as your age goes up, your risk goes up significantly. And this is broken down just by race, with African Americans on the top, and gender. So this is African American men, white men. This is a combined line, this lavender line, and then the dotted lines are blue is African American women and orange is white women. Just to note, I think there's some common misconceptions that colon cancer is a disease more common in men, and that is not true. It is diagnosed at equal rates in men and women, but women are less likely to get screened than men. That's probably due to more fears, they have more discomfort around the area. They're more uncomfortable with the whole idea of somebody doing a colonoscopy. But if you look back and you see that women are diagnosed with colon cancer at equal rates than men, we really shouldn't have any stigma about colonoscopy, especially given how common of a cancer it is. Just to note, does screening help us decrease death? Does it decrease morbidity? And it does. The death rates from colon cancer are declining. Every year they go well, not every year, but for the most part, they're on a trajectory of going down. And the reason they're going down, this MyScan colon was a huge study looking at data, and we think that probably the reduction in colon cancer can at least be attributed, 50% of that reduction at least attributed to screening and good screening methods. So, you know, the million-dollar question is, who do we screen and when do we start screening? And I'm going to touch briefly on this because you can see in my first slide it says start regular screening at age 45 to 50. And in my next one or two slides, we'll talk about what that means. African Americans, the screening age of starting still remains to be 45, through 45 to 50, depending, through 75. And then there's this group here, ages 76 to 85. And I have this conversation a lot with people, you know, I'm 80, should I really have a colonoscopy? And I think that's a discussion that you can have with somebody like myself or with your primary care or with the doctor to discuss, you know, does risk of colonoscopy, which is very small, outweigh the benefit of increasing life expectancy, overall health, that type of thing. And I tell people, you know, if you're in really good health at 80, then there's absolutely no reason we shouldn't do a colonoscopy. There's no increased risk in somebody who's 80 versus 70. It's not like the colon gets thinner or is more risky or anything like that. You know, maybe just people just don't necessarily want to do colonoscopies, but that doesn't mean we shouldn't. And, you know, we know that a polyp takes about 10 years to turn into a cancer, or has the potential to turn into a cancer over about a 10-year time span, which is where that 10-year gap comes in, the 10-year recommendation between colonoscopies. So if you're 80 and doing great, then there's no reason I should not do a colonoscopy, prevent you from having colon cancer, and, you know, have you, you know, increase your life expectancy. So that's just a touch on that. So for screening, you're considered to be average risk if you do not have any of these things. So you're considered average risk if you don't have a personal history of colon cancer, or adenomatous or tubulobilous adenoma polyps. So if you have a history of precancerous polyps or colorectal cancer, you're not average risk. If you have a family history of colorectal cancer, again, which I'll talk about in the next slide, if you have a personal history of inflammatory bowel disease, if you have a hereditary colorectal cancer syndrome, or you have a history of abdominal pelvic radiation. So this is about family history, because I get this question a lot. So what denotes a family history? So I'm going to start at the bottom, actually. Here you can see a family history of colon cancer or colorectal cancer, or an advanced adenoma, and that is defined as a polyp greater than a centimeter or with dysplastic features in a single first-degree relative diagnosed at age greater than or equal to 60. Then we start screening you at age 40. Now, many times people don't know this. They just say, well, my mom had a polyp, and I don't know what size it was, and I don't know if it had dysplastic features. But if we don't know, I generally err on the side of, well, if we don't know, then we treat it as an advanced adenoma, because if you don't know, you have to be cautious about it. If you do know, then that's great, and that helps us. Then you start screening at age 40, and then you follow in the regular guidelines every 10 years or less if you yourself are found to have a polyp. The other family history to talk about is colorectal cancer or an advanced adenoma in two first-degree relatives if they're younger than 60, or at any age really, or colon cancer in a single relative less than 60. So if somebody had colon cancer at age less than 60, or multiple people in your family had polyps, then we do a colonoscopy every 5 years, either starting at age 40 or every 10 years before the youngest person was diagnosed. So let's say you had a family relative or your father had colon cancer at age 45, we would start screening you at age 35 every 5 years. So hopefully that clears up what the family history question may or may not be. So here's, this just says if you have Lynch syndrome, then we start doing every 2 years at age 20. That is the most common inherited colon cancer. So if there's issues with that, let your doctor know, because you're going to have to start being screened at a very young age very frequently. So this is a big to-do, almost exactly 2 years ago. Not exactly, but, May of 2018, where the American Cancer Society came out and blew all our minds and said, we're not going to start screening at age 50, we're going to start screening at age 45. Why did they do that? Well, they used this MyScan model, and they looked at lots and lots of people, and they analyzed basically what they defined as an efficiency ratio. The number of colonoscopy, or the burden of colonoscopies on the healthcare system, divided by life years gained. And that gave them basically what they called an efficiency ratio. And the balance of burden to benefit and screening improved starting at age 45 instead of age 15. So here you can see the graphic, and there was actually 9 different efficient strategies. Those are the strategies that fall exactly on this line. And again, this is just looking at those efficiency ratios. So they looked at younger ages with lower frequency, so 40 every 5 years, 45 every 5 years, and then they looked at every 15 years at the other side of things. And they identified 9 strategies that all fell on that line right there. But 45 was one of the efficient ones, but it had the highest number of life years gained among the strategies with efficient ratios. So compared with the current recommendations of screening every 10 years, it resulted in 25 additional life years gained. So it gained the most life years while still being cost effective. So the new recommendations are really age 45. Now, I'm not going to go back to the slide, but why a few slides ago did it say 45 to 50? It said that because there are still insurance companies that will not cover 45. We're 2 years later and we're still not quite there. But I would say the majority are. So if there's any questions, we're happy at university hospitals to run your insurance and see if they will cover it starting at 45. I'd say about 75 to 80% of insurance companies are covering it right now. So now this is a big hot topic. What are the options of screening? So the direct visualization are colonoscopy every 10 years, CT colonography, which is a CAT scan colonography test. I'll just touch briefly on this right now, but this is very rarely done. And the reason is you still have to do the prep, which is obviously the most dreaded part. And then if they find a polyp, then you still have to get a colonoscopy after that. So many people do not choose this option. I'd say very few. And then flexible sigmoidoscopy every 5 years, which I would say is probably going to go away as a recommendation within the next year or two. Nobody's really doing that. And then stool testing. So FOBT, which is traditional blood testing in the stool, something called FIT, which is fecal immunohistochemistry, and Cologuard testing, which is the stool DNA, every 3 years. So let's talk a little bit about what those are. So FOBT, or the traditional stool blood test, is basically just to detect heme. Heme is a component of a red blood cell. So if you have any red blood cells in your GI tract, it will be detected in that. Now, the problem with this is that you can, for example, get a positive FOBT with eating red meat, because red meat obviously has heme. So you have to have dietary restrictions. It requires 3 separate stool samples to determine whether or not it truly is positive. So an FOBT is not the greatest test for screening, although it does still exist. A FIT is a much better choice. A FIT is a single stool specimen that detects a protein within human heme or human blood. It can be positive if there's intermittent bleeding. So for example, if you have a small colon cancer that's not bleeding at the time of the FIT test, then the FIT test can be falsely negative. But since it detects human protein, there's no limitation as to what you can eat beforehand. And then stool DNA, otherwise known as Cologuard, which detects precancerous cells, which are continuously exfoliated from the lining of, or from the surface of a cancer or a large precancerous polyp. Again, it's a single stool specimen, no dietary restrictions on this one. The FIT test is an annual test, and the FIT fecal DNA is an every 3-year test. This is a slide that I made that compares the FIT to the Cologuard to the colonoscopy. So they looked at almost 10,000 patients, and they stratified them into 3 groups: FIT, Cologuard, and colonoscopy. Cologuard, it was very sensitive for detecting colon cancer, 92, some people would quote 94% sensitive. So it's very good at finding colon cancers. However, it only had a 40% sensitivity for large polyps greater than a centimeter. Now, if you remember early on in my talk, I mentioned that there's these risky polyps that we consider risky, like greater than a centimeter or dysplastic features. Those polyps that we talked about being significant in your family history, those mean something to us. Those are more risky polyps. And those are the ones that are more likely, probably, to turn into colon cancer. And unfortunately, Cologuard misses about 60% of those. So that, I think, is one of its main limitations. FIT testing, obviously less sensitive, about 73% sensitive, and it has no sensitivity for polyps, no matter how many times you do it. Now, FIT testing, just a note on that, if that's what your doctor is doing or offering, or that's what you've had done, FIT testing is recommended every single year, whereas Cologuard is every 3. So if you do a FIT test with 73.8% sensitivity times do it every single year, that sensitivity goes up, and by about the end of the 3rd year, you are about at 90%. So I would argue that the FIT test has almost the same sensitivity if done every year for detecting colon cancer than a Cologuard test does. Than a Cologuard test does. However, it doesn't have sensitivity for polyps. The cost effectiveness, in general, there's been tons of modeling studies to show which is more cost effective. People would assume that stool-based testing is, but in fact, it's probably not. And any screening test is more cost effective than, the cost of cancer treatment, or far outweighing the cost of screening. And the reason colonoscopy is probably still as cost effective as Cologuard is because we're removing polyps and decreasing the incidence of colon cancer more than if we were just doing stool testing. And I'll touch on that in this next couple of slides. So Cologuard is covered by Medicare every 3 years, age 50 to 85 or 45 actually, as a screen. If it is positive, you then need a colonoscopy to follow that up. And if you've ever had a positive Cologuard, you cannot go back to Cologuard. Once it's positive, you move to the colonoscopy arm and stay there. Patients who cannot use Cologuard. Now, I say cannot, doesn't mean it won't work. It just means all of these people were excluded from the study. So if you had a history of colon cancer, I would advocate don't ever use colon cancer, or Cologuard. If you have a history of a polyp or an adenoma, they excluded those people from the studies, and other related cancers. People who have had a positive result from another colorectal cancer screening modality in the last 6 months. So if you had a positive fit, there's no reason to then do a Cologuard. Anybody who has a familial cancer syndrome, I mentioned briefly, but any of these other ones. And patients who have a condition that is associated with high risk for colon cancer. Those are IBD, like ulcerative colitis or Crohn's, FAP or other familial hereditary cancer syndrome, and a family history of colon cancer. These patients were excluded from the study. So if you had a family history of colon cancer, they excluded you from the study. Hold on one second. I think my phone is acting a little weird. I'm having to talk through it. So I'm going to talk really close here, and hopefully you guys hear me. Going backwards here. Got to go back. All right. So family history of colon cancer. I hope this is, this is just the age we're in here with this phone up to my mouth, but it is what it is. So a family history of colon cancer, again, this is defined as we defined earlier in the talk. Either one family relative with colon cancer less than 60 or 2 greater than 60. So the advantages of colonoscopy, to me, are essentially polypectomy, which is removal of polyps. So colonoscopy detects almost 100% of polyps. I would say it's about 95%. There is a miss rate, but that in comparison to Cologuard, which detects 40% of large polyps. So this doesn't stratify the small polyps that you're also getting out on colonoscopy, and detects 100% of cancers. It provides diagnosis, but also therapy. So let's say I'm in there and see a big polyp. I'll take it out. And then by that notion, I'm then preventing the development of colon cancer. So if you have a stool test that's negative, let's say, and it missed a large polyp, and then you get lost to follow up or something like that, we could be missing the development of a colon cancer. That doesn't happen in colonoscopy. Limitations, there is some inherent risk to colonoscopy, albeit it's very, very small. The risk is probably about 1 in 5,000, and the risk is bleeding, especially if we're doing large polypectomy. So when we do call you to schedule your colonoscopies, we'll discuss, are you on any blood thinners? And we'll have you stop those blood thinners before the procedure, depending on which one, depends when you stop it. The availability, so there's not a ton of gastroenterologists doing colonoscopy. Compliance, patients don't necessarily want to get colonoscopies as frequently as we think they should, and cost, because there sometimes is a copay. I will add, Medicare does cover average risk screening colonoscopy, and most insurance companies free. So that's sort of included in your benefits. This is a schematic of the development of a colon cancer from a polyp. So you see that's normal colon in the top left, and then it sort of develops into that little red bump. And then intermediate is that's a big polyp. That's what we would call a high-risk polyp. So that's greater than a centimeter with probably with dysplastic features. And you can see, that we would just take something like that off in your procedure. And then it's getting a little bit larger. We can still take that one off in that late picture, but then as soon as you get to the last picture, that's cancer. And that's not removable during a colonoscopy. This is just a picture of some lesions that are flatter and easier to miss. This is just telling you guys, again, as I mentioned a few times, the adenoma-carcinoma sequence, which is that most colon cancers come from polyps or adenomas. So the progression from an adenoma to a cancer takes about 10 years, which is where we came up with that every 10 years recommendation. This is saying that polypectomy prevents cancer, as we talked about, but even if we find a cancer, so even if I find a cancer, if I find it early enough, there's a 90% survival if that cancer is localized. And even if it's regional, like spread to the lymph nodes or surrounding organs, it's still about 70% survival at 5 years. So these are great numbers, honestly. 90% survival at 5 years is a great statistic. This is something I put in there. I'm not sure if you guys will like this or not, but I really believe strongly in empowering my patients to ask the right questions and find the right doctors. This is something that one of our societies published called Tools for Patients to Enhance Colonoscopy Quality. And it basically is giving you guys some questions to ask what they called prospective colonoscopists, or I guess whoever's going to do your colonoscopy, help ensure a high quality exam. And these are things your gastroenterologist or surgeon or whoever's doing your colonoscopy should be monitoring. So what is your adenoma detection rate? That should be high. We should be seeing a lot of polyps in people if we're doing a good job. So the number should be somewhere greater than 25%. How often are you getting to the cecum, which means how often are we getting to the end of the colon? And are you using split dosing bowel prep? So I'm going to touch on this briefly right now because I know we got a lot of questions even before the talk on prep, and I wanted to touch on it. So I use what's called split dosing bowel prep. So what that means is, let's say your colonoscopy is at 10 a.m. on a Monday. So on Sunday, you would be on a clear liquid diet, and that includes things like lemonade, black coffee, ice pops, Jell-O, chicken broth, beef broth, that kind of a thing. Then around 5 p.m. in the evening, we'll have you drink half of the bowel prep. And generally the bowel prep is basically 2 liters these days. There is still the Go Lightly option, and sometimes we have to use it, which is the 4-liter gallon that everyone's heard of. But generally we can avoid using that. And generally we use a 2-liter prep. And we have many different kinds, some that are prescribed and sent in. Some patients I can use Miralax mixed with Gatorade. It all depends on you and your lab profile and what medications you're on and if you have kidney disease and blah, blah, blah. But I should mention there are many preps on the market. Some are covered by insurance, some require a copay, some we have you mix yourself. But in general, the prep is about 2 liters. You would drink 1 liter around 5 p.m., evacuate some of your bowels, and then you go to sleep. And then I ask you to wake up 4 to 5 hours before your scheduled time. So if it was 10, you'd wake up at 5 a.m. or 6 a.m., somewhere between 5 and 6, and drink the other liter, evacuate the rest of your bowels, and then head over to us. That leads to a more effective bowel prep, and it requires, and it gives us a better view, and it gives also better patient compliance. More patients will drink more of the prep if done that way. So that is I think the best kind of prep that we have. Okay. And then look at your endoscopy report after your procedure. Does it include photographs of the colon? Is the bowel prep quality described to a good degree? Is it telling you the score of your bowel prep? These things are important, and we should be providing them for you. Are people getting tested? No. I shouldn't say no. They're not getting tested to what I would like, which is 100%. But fewer than half of Americans over age 50 report having had a recent colon cancer screening test. So because of the low testing rates, only about 39% of colon cancers are detected early. And like I said, those ones are the ones with amazing outcomes. If you detect localized colon cancer, you know, 9 out of 10 people will survive. So even if we're finding colon cancer, if we find it early, it's very treatable and beatable. Ohio's doing better than other places. We're at about 66%. This statistic is from 2014, but it's still not close to 100%. And actually last year at university hospitals, we had a huge push to try to get 90%. We didn't get there. but we did get closer, and at university hospitals, our numbers were somewhere between, depending on where you were, somewhere between 70 to 80. So we're pushing, we're getting better. And this is just a summary slide on my thoughts. So I think colon cancer is the second leading cause of cancer deaths in the U.S., yet it can be prevented by finding and removing precancerous polyps. And the best way to do that is performing a screening colonoscopy in asymptomatic people. The dilemma is that about 40% of people eligible to be screened do not get screened. And there's a variety of reasons for that. And frankly, people just not wanting to have a colonoscopy. And I wanted to touch on that briefly and just say, we are extraordinarily respectful people that perform colonoscopies. We understand that it's an uncomfortable thing and that nobody wants to get that done. And I would expect everybody that walks through my door to get treated with respect and kindness and empathy, and that we would never do anything to make anybody feel like it's a violation. It's a very controlled environment. We understand there's anxiety, and anything revolving your body and revolving medicine can be anxiety producing, but we do everything we can to be to maintain just such high standards of respect. And I would just encourage you to talk to people who have had it done, especially at Geauga, what their sort of views are on the whole process, because really, I've been there. I've had my own colonoscopies, and I can tell you, yes, it is anxiety producing, but that doesn't mean that you shouldn't get it done. And I promise you, there's no funny business going on in there. I'm just looking at the colon and nothing else, and just trying to save lives. My third point here is that if the detection rate of dangerous polyps is 42%, what is left unsaid in that statement is that 58% of the most dangerous polyps are not detected by Cologuard, and I feel that's unacceptable. It's the last group of patients, though, which Cologuard is best suited for people who just don't want to get a colonoscopy, knowing that it can prevent colon cancer. Listening to this talk or, hearing from loved ones, if you still just say, I absolutely won't do it, then Cologuard is an option, because 42% is better than nothing. I'll leave you on this slide, which is that colon cancer is preventable, it's treatable, and it's beatable. This is an old slide, and actually, it should say 45 here, but anyway, you get the point. So at this time, here's the number. This is the number to call to schedule for a colonoscopy with me. I will take any questions now that you have. I think the way it will work is Mark will help me go over them and send them to me, and I'll answer them for you. Thank you for your time.
Thank you, Dr. Soika. And just for all of our attendees, so you know that this webinar is being recorded, and you will receive an email probably next week with a link to this video and more information of how to reach Dr. Soika. So Dr. Soika, as you've mentioned, we had lots of questions about the PrEP, and you touched on that a little bit in your talk. A lot of people have mentioned a pill that people have used in the past, and can you touch on that?
Sure. So there is no approved pill PrEP, no safe pill PrEP. So, as far as safety goes, I'm a big advocate for safety, and I would never prescribe a PrEP that I don't think is safe. So at the current time in my practice, there's no pill PrEP. Sometimes we will ask patients to take some pills like Dulcolax, which is an over-the-counter laxative or stimulant laxative, in combination with a PrEP, a liquid PrEP, to help things along. But there's no only pill PrEP that I'm aware of that is safe and on the market right now.
And along those lines, are you familiar with any other PrEPs that are coming out on the horizon that may be introduced?
So there's always PrEPs coming out. I would say the majority of them are not much different from one another. The most sort of recent one to the market has been what was called Prepopic, but is now called Clenpic. Clenpic is a nice option because it is actually just 8 ounces of prep at the 5 p.m. time slot, followed by 5 glasses of water. And then when you do the wake up 4 to 5 hours before, it's another 8 ounces, followed by 3 glasses of water. So that only totals 8 ounces instead of 16 ounces each time. So it's half the volume of prep. The problem with Clenpic is that it's expensive, but I'm always, it gives a decent prep, so I'm happy to prescribe it. But I would say the general copays run between $50 to $100 for it.
Our next question that came in prior to the talk was asking about the anesthesia that's used during colonoscopies. This person had some trouble coming out of their anesthesia and lasted almost 24 hours. Can you discuss that?
Yeah. So the caveat to this is that people use different anesthesia in different places. So I'm going to just talk about where I work, which is at Geauga Hospital, University Hospital Geauga in Chardon. And I want to be clear that this may not be the same across the system, but I will talk a little bit about what they do other places. So there's 2 kinds of sedation for a colonoscopy. One is called moderate sedation or conscious sedation, and that generally involves a combination of something like fentanyl, which is a hefty, pain medication, and Versed, which is a benzodiazepine or a relaxing medication. Those medications can kind of snow you for a while. So many times people will feel kind of out of it, especially if they required high doses of anesthesia, if they're getting moderate sedation. That doesn't mean that moderate sedation is bad. It just means sometimes the lingering effects are longer with moderate sedation. At Geauga, we have a nurse anesthetist or an anesthesiologist in during the whole case. And in that setting, they use propofol, which changes the sedation to something called MAC anesthesia. When you have MAC anesthesia, you're allowed to use, or the anesthesiologist is licensed and trained to use propofol, which is a quick on, quick off sedating medication. So people come out of it more quickly and with less lingering effects. It doesn't mean you might not get a little fentanyl or a little Versed. Sometimes patients need that as well. Some anesthesia, it depends on the patient. It's not a one size fits all thing. But I think if you limit the fentanyl and Versed, many times you're able to come out of the procedure a little bit more quickly with less lingering effects. But again, these drugs are metabolized differently in different people. So I would encourage you to talk to your doctor, talk to the gastroenterologist about it before the procedure. And then even if you have questions, talk to them at the procedure, talk to the nurse anesthetist if they're available, the anesthesiologist, and express these concerns.
Okay, our next question. This person has some family history. Her sister has stage 4 colon cancer, just 1 year shy of her next colonoscopy. She has another sister that just had polyps removed that were precancerous. Her dad had many polyps. She's 57 and had her first colonoscopy almost 5 years ago with no polyps. But her gastroenterologist said she's good to go for 10 years, and she doesn't seem to be very comfortable with that.
Mm-hmm. So based on the risk factors that this person mentioned, they should be in an every 5-year cohort screening group. I would actually consider talking to this patient a little bit more and getting a pedigree, which is basically writing down all the cancers in the family, because this person checks off a few boxes of somebody that has some risk factors for a genetic cancer syndrome in their family, something like Lynch, which I talked about. I mean, it's wonderful that this person did not have any polyps, but either way, Lynch or no Lynch, I would recommend somebody with that family history would get screened every 5 years.
Okay. Our next question is, a person had a colonoscopy and they started getting ill a few days later. Fatigue, temperature. They ended up saying they had diarrhea for 7 weeks. They're concerned that maybe it was the facility. The doctor retired and they had no issues prior to a different colonoscopy that they had. They're looking for obviously a new place to go for the next colonoscopy and feel that, you know, maybe infection was an issue. And can you comment to, you know, it's not common to have 7 weeks of diarrhea after a colonoscopy, correct?
Right. No, so it's hard to say what happened in that scenario, and I'm sorry for that person. Sounds like a very trying event for you. It's sort of unclear what happened. I never say never because you don't know. But colonoscopy, you know, we have extraordinarily strict guidelines on how we're cleaning these scopes. We're monitored twice a year. They come in, they test everything. Everything is super, super sanitized to the point where, you know, the nurses are wearing triple gloves because it's very, very high quality stuff, high disinfectant. But you know, you never say never, and I'm not sure what happened there, but I would assure you that at least where I work, where I've, you know, been the director of endoscopy at University Hospitals Geauga Medical Center for the last 3 years, it is the safest safety standards. I can attest to that.
Our next question is, why is it that colon cancer is found more as we age?
You know, we're not entirely sure. It probably has something to do with cell breakdown, but we don't know exactly the reason why. We just know that incidence rises with age.
Our next question is, which medical areas screen for anal cancer? This person's GYN didn't do it, or their PCP, and the first gastroenterologist didn't, but the most recent one did DRE prior to the colonoscopy and discovered this person had anal cancer.
Oh, I'm sorry to hear that. That's, so there is no screening necessarily for anal cancer in an average risk person. If you have risk factors like HPV or other risk factors, then there generally is some screening. But I wouldn't know, you know, about this person's specific history. But generally, obviously during a colonoscopy, we're looking for anal cancer. But I would say that the most people that have risk factors for anal cancer get screened either by a primary care doctor who's doing a perianal exam every year, a gynecologist who also could do that, or a colorectal surgeon. But if I knew this patient's, you know, HPV positive or history of anal cancer, then obviously you would screen that patient. Anybody who can do an exam really can screen for anal cancer.
Can you talk about diet recommendations leading up a couple days before the colonoscopy, not just the liquid diet?
Sure. So, so I do continue to recommend a low fiber diet for about 5 days before the colonoscopy. And the reason for that is those things stay around, which is wonderful for your gut. It's wonderful to have fiber in your gut. The only time it's not wonderful is when I have a very small scope in there with a very tiny hole and all these little seeds are getting stuck in it. So that becomes an issue for you and for me, and it also decreases the prep quality. So generally we ask people to avoid very high fiber foods like nuts and seeds, corn, things that stick around in the colon for about 5 days beforehand.
Can you explain what it means to be diagnosed with pseudopolyps?
Sure. So pseudopolyps are generally an inflammatory polyp seen almost ubiquitously in inflammatory bowel disease. So generally, a pseudopolyp is a sign of the colon mucosa repairing itself. So there was some damage to it, and it's scarring down and developing a polypoid-like structure, which is really just a scar in a tubular structure. So generally, it's a sign of mucosal healing or long-standing mucosal damage in inflammatory bowel disease, but we can see it in other scenarios, but generally it is not removed and is not precancerous.
So a person who has an adenoma and had sessile polyps found at 46-year-old is asking when their children should have their first colonoscopy. There is colon cancer in their family history.
So that's a good question, and the answer is if you are the parent of a child and you at 46 had polyps found, if they were advanced or greater than a centimeter, then your child should start getting screened at age 40. It's hard to say about with the colon cancer in the family. So if there's a colon cancer in the family as well, in somebody that's less than the age of 60, then you would start screening. So if you with polyps plus family history of colon cancer in somebody less than 60, then you would actually start screening your child at age 36, which is 10 years younger than you, and not 40.
Can you explain virtual colonoscopy and what might be missed on that?
Sure. So I touched on this briefly at the beginning, and sorry if I rushed through it. It's just not the bane of my existence, but something I don't prescribe that much. And a virtual colonoscopy is essentially where you do a full colon prep. So you still clean out the colon just like you would in a colonoscopy. And then you go to a CAT scan, where a CAT scan will take pictures of the colon and look for cancer as well as large polyps. Small polyps can be missed on a virtual colonoscopy, especially less than 5 millimeters. And if a polyp is found or detected, or a colon cancer for that matter, on a virtual colonoscopy, it should be followed up with a regular colonoscopy. My opinion on virtual colonoscopy is that its utility is really best served in patients that fail a colonoscopy. Like, let's say I touched on how 95% of colonoscopies we should be getting to the end. In that 5% where just the anatomy is not correct and it's hard for the endoscopist to get around, or for whatever reason they couldn't get to the end, in that setting, I sometimes will recommend following it up with a virtual colonoscopy to make sure there was nothing missed in the segment that we weren't able to reach in the colonoscopy. So I would say I find myself ordering maybe one of those a year, but that's essentially how I use it, and I think a lot of other gastroenterologists use it.
Our next question is, should a colonoscopy be attempted again if unsuccessful the first time?
That's a wonderful question, and the answer is it depends. I'm happy to always talk to patients about this in the office or over the phone or virtually or what have you. And I'm sorry, my computer just froze for a minute here, so if you're not seeing me, I'll get back on in a minute. But yes, so it really depends on the reason why the colonoscopy wasn't completed, who was doing it, how long ago it was, and sort of a lot of different reasons there. So I think before jumping to the conclusion of yes or no, that would be a wonderful conversation to have with someone like myself or another endoscopist.
Our next question comes from a person who is stressed about the prep because of their hemorrhoids are so bad. How do you work on that problem?
Generally, so if people have bad hemorrhoids, I try to, shrink them down as bad as you can beforehand. So sometimes patients will call with this complaint and we'll actually give them hydrocortisone suppositories for the week before. So every night or even twice a day for the week preceding the colonoscopy. We really try to shrink these down. We have patients do some sitz baths as well, where you just kind of squat in a couple inches of warm water to allow for increasing blood flow to the area to promote healing. Then we add suppositories to really try to calm them down. But, any colon cleanse can lead to a flare of the hemorrhoids, but I think if you sort of pre-treat, that can be helpful.
Can you explain just what some of the symptoms are of colon cancer?
Sure. So generally, the things that we worry about are things like rectal bleeding. So if you see blood in your stool or even black tarry stool, a change in your bowel habits. So if you're somebody that went to the bathroom every day and now you're noticing increasing constipation, or your stools used to be nice and formed and now they're kind of coming out stringy like a pencil, or you're noticing abdominal distension that you once didn't have associated with a change in your bowel habits, as well as sort of more vague symptoms like fatigue, night sweats, fevers, chills, unintentional weight loss, and then things on your blood work, like if your doctor's identified a new anemia or iron deficiency, those would be all signs and symptoms of a colon cancer.
Our next question is wondering if there's any progress being made in Cologuard technology to increase the detection of larger polyps.
Great question. I'm actually unaware of if that's happening or not.
And is there any connection between bladder, prostate, and kidneys with colon cancer?
No, not bladders, prostate, or kidneys. There is an association with some of the other cancers. So breast cancer, ovarian cancer may increase your risk of colon cancer. And then there's a couple of other hereditary cancer syndromes, but none that include bladder, prostate, or kidney that I'm aware of.
And our next question is, what sort of prep would be acceptable for someone with stage 3 kidney disease?
That's probably going to be something like a SU prep, which is the one I talked about at the beginning, which is one I prescribe to most of my patients, which is a 2-liter prep that's prescribed. So you do the 1 liter and then the 1 liter. And it's isotonic, so it doesn't affect the kidneys. People always ask me, I have kidney disease and my doctor said I need to limit my fluids, and this is a concern also in heart failure and things like that. And I tell people actually that the colon prep solution is isotonic, so it doesn't get filtered by the kidneys, it doesn't go into the heart, it stays in the colon lumen. There's none absorbed into your vasculature or your blood vessels, so it just stays in the colon lumen. So it doesn't really affect the kidneys or the heart or anything like that. So you can drink 2 liters and not even count it towards the amount of fluids that you took in that day. The reason that there's only a few preps safe in stage 3 kidney disease is because of some of the electrolyte balance. So there's only a few that are safe or at least tested in kidney disease patients.
Our next question comes from someone who was taking metamucil, was advised to take it years ago, and is still continuing, but they're getting indigestion from it. Is there any thoughts on how to help that? Is it just chewing antacids, or is there something more?
That's a difficult question, and it may be because the metamucil has a bit of an orange flavor, and that orange flavor can increase acid reflux. So you may want to switch to something like Benefiber, which is a tasteless and flavor-free formula, and see if that helps. And if not, maybe go to your primary or a gastroenterologist to talk about worsening acid reflux or indigestion. But you could also try something over the counter like Tums, or even a couple weeks of Zantac, or I'm sorry, they don't make Zantac anymore, Pepcid.
Our next question is, once you're diagnosed with IBS, does it ever go away? And does it increase the chances of getting colon cancer? The only signs for screening are blood in the stool. But when this person says they have some wiping, that they see some blood, but they're not sure if it's that or just they're wiping too hard.
Mm-hmm. Yeah, and so there's a couple questions mixed in this. So the first is, does IBS ever go away? And the answer is, I wouldn't say it ever, quote, goes away, but it ebbs and flows, and it has its flares and its crescendo. So it's definitely a disease that comes and goes and can be sort of at bay for a very long time. And I do tell people our bowels do change with time, sort of like our hair changes. There is a change in bowel habits with time. That not necessarily doesn't mean that you shouldn't talk about it with your doctor, but it can sort of be at bay for a very long period of time. Does it increase your risk of colon cancer? No, it does not. And is the bright red blood that you're seeing when you wipe intermittently because of hemorrhoids or a fissure or something quote unquote benign, or is it because of colon cancer? That I can't answer over this talk, and I would say it could be either of them. If it's over a long period of time, it's probably less worrisome than if it's something new. But either way, I'd make sure that you talk to either a gastroenterologist or even a primary care doctor about that.
Once polyps have been removed, will they return? And if so, how long?
Great question. No. Once a polyp is removed, it will not return unless it wasn't fully removed. And that's a special situation. And we generally talk to our patients about that if it was a large polyp and we missed some of it or something like that. But we do say where there is one polyp, many times there's more polyps. So once if we're taking out 3 or 4 polyps in you, the likelihood that at your next colonoscopy you'll have polyps is high because you're kind of a polyp former, for lack of a better word. So if you keep coming back and there's more polyps, it doesn't mean they were missed or that they're at the same site. It just means you're somebody whose body is prone to forming polyps.
Is there an increased risk with repetitive bouts of diverticulitis?
Increased risk of colon cancer?
Yes.
No increased risk of colon cancer, but repetitive bouts of diverticulitis do have their own risk and complications, which include stricturing or blockage, change in the anatomy, which can make it difficult for stool to get by, fistula, all different other complications. Doesn't increase your risk of colon cancer, although I would mention many times people are diagnosed with diverticulitis and are told to get a colonoscopy, and that's for a different reason. That's because diverticulitis is diagnosed on a CAT scan, and it looks like thickened area in the sigmoid colon generally, where around the diverticula. But because it's a CAT scan is a 2D image of a 3D space, we can't always see if that thickening is just because of inflammation or swelling, or if it's because of an underlying neoplasm or a cancer. That's why we recommend direct you with a colonoscopy for a follow-up. So it's not that diverticulitis increases your risk of colon cancer.
Well, we're up against it at 1 o'clock, so I want to be mindful of everyone's time. Is there anything that we can talk about in closing, particularly with where we are in the climate of today, in terms of, people maybe having appointments that have been postponed and now they're able to get back in, but have some concerns. So there's that, and we also have some telehealth options that are now available today that weren't so available before. So maybe you could touch on some of those.
Sure. So I'll touch on telehealth first and close with some thoughts on COVID. So with telehealth, the majority of the gastroenterologists, at least within our system and probably globally, are doing appointments mostly through telehealth. And I think that's great because there's no way or no good way to maintain good social distancing in the office. And we can still have many of these, 99% can be done over telehealth. And I've really found it to be really successful and had good patient compliance with it. And I was actually talking to Mark about telehealth the other day and saying, I think it's going to be something that I keep in my practice forever, at least for part of it. And the reason is because it's flexible. I can, I've had so many patients talk to me from their car on a lunch break or, a break from work, or, they don't have to take all their kids into the office. And it's been really great for that. And it also, it helps reach people who may not, may be at a very far distance and can't come, get a ride to and from. So I think it's really been a great way for us to reach out to patients without having to have you come to a standard schedule in the office. Let's talk a little bit about COVID. So we all know that COVID is out there, but that doesn't mean that we shouldn't be taking care of our health. So our governor has supported us opening back up surgeries, elective surgeries, and procedures. And for us, that means doing endoscopy and colonoscopy. And that includes screening colonoscopy and surveillance colonoscopy for people with a history of polyps. What we are doing is we're having people get tested for COVID before getting their colonoscopy. So if you have a colonoscopy appointment 3 days prior to your colonoscopy appointment, we have you go to one of our testing sites. Geauga has one right in the front of the building, and there are other ones scattered throughout the system. And you go there and you drive up, and they actually just swab your nose just very gently with a nose swab. It used to be these, if you've heard of anybody getting COVID tested, they were like these swabs that went back into the brain, basically. That's exaggerating, but they were apparently they went very far up. These ones are very gentle, quick, takes less than 2 minutes to get it done. But we are doing that for your safety and our safety, so that we know basically if anybody has COVID and can take extra precautions. Even without the presence of it, you know, none of my patients so far have tested positive, but even without that, we're still wearing significant PPE, masks. We're asking patients to wear masks into the hospital, and we put a mask on after we're done with the procedure. So I was actually saying, you know, to some people today when I was talking to them this morning, it's interesting because I think it's actually safer in the hospital OR than it is where I do my endoscopy than it is in the grocery store in Heinen's, that's for sure, because, you know, it's just so much precaution. So right now I think is honestly an extraordinarily safe time to come in and take care of your health.
Well, thank you to you, Dr. Soika, for presenting this information today, and thank you to all our attendees. Again, you will be receiving an email follow-up with the link to this recording, should you like to go back and watch it or share it with any of your friends or family. And we'll also provide you with opportunities to schedule an appointment or schedule a colonoscopy with Dr. Soika, as well as a number of locations across our system. You'll have the link to all that information. Dr. Soika, any closing comments?
No, just thank you guys so much for coming today. I know it's a scary time and we're all, you know, just doing our best here, but I appreciate you guys taking the time to spend in your day with me today, and I hope you guys learned something.
Thank you. That'll conclude today's talk. We hope to see you again on future talks.